Welcome to This Explainer. Okay, today we are tackling one of the most critical, yet honestly surprisingly tricky challenges in modern operating rooms. We're talking about respiratory management during urological and gynecological robotic-assisted surgery. Now, robotic surgery has completely revolutionized pelvic procedures with its incredible precision, but it creates a really unique and frankly profound mechanical stress on the patient's respiratory system. So our goal today is to unpack the data from a comprehensive review in the British Journal of Anaesthesia, and we're going to equip you with the optimal, evidence-based ventilation strategies, focusing heavily on moderate PEEP and mechanics to keep your patients safe.
Here's our roadmap for today. First up, the robotic surgery problem. Second, finding the PEEP sweet spot. Third, optimizing ventilation modes. Fourth, strategic recruitment maneuvers. And finally, key takeaways for your practice.
All right, let's dive into part one, the robotic surgery problem.
Take a look at the extreme head-down angle we're dealing with here. This is the steep Trendelenburg position. It is an absolute necessity for urological and gynecological robotic access. But when you take that severe tilt and combine it with pneumoperitoneum, the gas insufflated into the abdomen to give surgeons room to work, you are effectively crushing the patient's lungs. It is literally like placing a heavy anvil right on their chest because the weight of the abdominal contents shifts straight into the thorax.
So, how does this mechanical domino effect actually break down? Well, step one, we introduce gas insufflation, creating that pneumoperitoneum. Step two, this drastically shoots up the intra-abdominal pressure. And step three, all that pressure forces the diaphragm upwards, leading directly to compressive atelectasis, meaning those tiny air sacs in the lungs just collapse, and you get a massive reduction in respiratory system compliance. In fact, electrical impedance tomography actually shows us that just starting mechanical ventilation increases silent or atelectic areas in the dependent dorsal lung. Add in the pneumoperitoneum and that steep Trendelenburg position, those silent spaces get significantly worse.
Which brings us perfectly to part two, finding the PEEP sweet spot.
PEEP, or positive end expiratory pressure, is basically how we fight back against this compressive atelectasis. But that begs a massive clinical question, right? How much pressure is too much? Because simply blasting the lungs with high pressure is absolutely not a magic fix. It can actually cause as many problems as it solves, so we really need to find that Goldilocks zone.
If we map out the three tiers of PEEP based on the clinical data, a very clear picture emerges. Let's look at the top. Zero PEEP, or ZEEP, is just plain dangerous. Applying zero pressure at the end of expiration during these surgeries leaves the lungs entirely vulnerable to compression, and that causes severe atelectasis and hypoxemia. Now skip down to the bottom row. High PEEP, which is anything over 10 centimeters of water. Sure, this forcefully opens the lungs, but it heavily restricts venous blood return to the heart. That causes hypotension and often means you're going to need vasopressors and a greater positive fluid balance. So the middle row is our winner here. Moderate PEEP, between 4 and 8 centimeters of water, gives us the optimal balance. It maintains aeration while preserving hemodynamic stability.
When we pit these two extremes against each other, the data really just speaks for itself. High PEEP pushes intrathoracic pressure so high that it compromises the cardiovascular system. On the flip side, ZEEP allows the lungs to essentially pancake under the weight of the abdomen. You get significant loss of volume and massive silent spaces in the dorsal lungs. That moderate 4 to 8 centimeters of water range, that is your evidence-backed sweet spot for keeping the lungs safely open without causing systemic chaos.
Okay, part three, optimizing ventilation modes. Now that PEEP is dialed in, how are we delivering each breath?
We are all super familiar with volume-controlled ventilation, or VCV. It guarantees a set volume with a constant flow. The problem is, under the extreme abdominal pressures of robotic surgery, VCV leads to sharply higher peak airway pressures. But check out how pressure-controlled ventilation, or PCV, changes the dynamic. By using a decelerating flow pattern and ensuring a constant driving pressure, PCV actually results in lower peak airway pressures, higher respiratory compliance, and, interestingly enough, better carbon dioxide clearance. In the super-rigid environment of a pneumoperitoneum, PCV's uniform alveolar inflation is just generally superior for managing those peak pressures.
And when you utilize PCV, you really want to pair it with this number, 6 to 8. We're talking about a protective tidal volume of 6 to 8 milliliters per kilogram of predicted body weight. Now, while optimal tidal volumes in this specific surgical setting are still being researched, combining this standard protective range with pressure-controlled ventilation and moderate PEEP is, right now, the most robust and reasonable strategy to protect the lungs.
Moving right along to section 4, Strategic recruitment maneuvers.
So what is a recruitment maneuver, or RM? Basically, it's a technique to transiently increase inspiratory airway pressure. Think of it as a lung reset button. The goal is to aggressively but safely pop open those collapsed dorsal alveoli to minimize atelectasis and recruit a lot more surface area for gas exchange.
Check out that staircase effect mapped out on these charts. This represents a stepwise pressure recruitment maneuver over time. So instead of just slamming the lung with high pressure instantly, which we don't want to do, you safely and gradually step up the pressure over 5 to 6 cycles. Once you hit your target pressure, you hold it, usually for about 30 seconds. That gives the alveoli time to pop open, and then you safely step back down to your moderate PEEP level.
To execute this safely, the authors lay out a really clear 4-step framework. First, use progressive PEEP incrementation to reach a predefined pressure trigger. Second, don't just do it randomly. Execute RMs at predefined times, like right after intubation or immediately before and after pneumoperitoneum insufflation. Third, only apply supplementary RMs during the surgery if oxygenation actually drops. And fourth, and this is absolutely crucial, carefully monitor ventilatory pressure and cardiac output. Remember, while RMs are incredibly helpful for aeration, they can cause temporary but severe hypotension, so they have to be titrated with immense care.
All right, Section 5, let's bring all this data together into key takeaways for practice.
If we want to mitigate the severe respiratory risks of steep Trendelenburg and pneumoperitoneum, it really comes down to these 4 rules. 1. Abandon ZEEP entirely. 0 PEEP harms your patient's lungs. Full stop. 2. Adopt moderate PEEP between 4 and 8 centimeters of water so you can balance aeration with hemodynamic stability. 3. Utilize pressure-controlled ventilation paired with a 6 to 8 milliliter per kilo tidal volume to limit those dangerous peak airway pressures. And 4. Implement highly monitored, stepwise recruitment maneuvers at key surgical milestones to preserve lung aeration.
I want to leave you with a question to chew on. As robotic surgery continues to rapidly evolve and become just an everyday occurrence, is your ventilation strategy evolving with it? Relying on old habits in these high-stress physiological environments just isn't going to cut it anymore. I really hope this explainer empowered you with the structured knowledge to optimize your ventilator the next time you step into a robotic suite. Thanks so much for joining me, and keep learning.